1 in 4 skin of color patients want aesthetic treatments. And we know that this is a growing population. In fact, the fastest subtype of aesthetic patients are skin of color patients. So whether you know it or not, these patients are in your practices. And what we don't want to do is have to send them away and lose business because you don't feel comfortable with laser options. And as well, you don't want to create complications because you were unaware that you had a skin of color patient. I'm going to get to that a little bit more, but on this table, we can see that this population is estimated to grow to 50% by 2045. And when we look globally, skin of color makes up about 80% of the global population. In terms of what are the demands and what are people seeking, the number one skin problem in the world is hyperpigmentation. It really is a significant problem globally, both from medical aspect and also aesthetic aspects, followed by acne, melasma, PIH, hair removal, and pseudofolliculitis barbae. So there are nuances in skin color, and all skin of color is not the same. And people within different ethnicities have different types of skin. So you can't really talk about, Latina skin or African American skin or Caucasian skin, because within these subtypes, there's a lot of differences. And increasingly, we're seeing mixed ethnicity. So mixed ethnicity leads to even new skin types. There are skin types evolving that we're not even aware of. So if you've ever heard me speak before, you may have seen this slide, and I say beware of the Oklahoma blonde. Okay? Now, whether you know it or not, the Oklahoma blonde may be part Native American, particularly the Cherokees are from Oklahoma. And it may not be so obvious. Here is a child with blonde hair, and she's very fair, and she's a child of a Native American mother. Now, you don't want to find out when you're treating this person for hyperpigmentation and scarring that they're, indeed, are a skin of color patient, because you chose laser settings for a Fitzpatrick 2 when their skin is behaving like a 4. So this is, I see, the area where we can really lead our specialty in understanding that these mixed ethnicities are really in our practices, and we have to be diligent in seeking them out. So, what are the properties of the skin of color? Well, we know there is delayed photoaging in our skin of color. And when we're talking about skin of color, we're talking about 4 through 6. So there's a delay in photoaging, anywhere from 10 to 15 years. And we also know that hyperpigmentation is more prevalent. And the melanocyte is very labile and very fragile. So it takes a minimal type of injury or inflammation, just a little burn from cooking, a scratch from the dog, can lead to hyperpigmentation. And the hyperpigmentation in skin of color is more prominent and more persistent. And just going back to, basic science here, just remember that it's not the melanocyte number that is increased in skin of color. It's the melanosomes, right? So the melanosomes are much more in skin of color than in light, and this is what's depicted there. It's the melanosomes, and it's also the way the melanosomes are aggregated. So when we look at skin pigmentation, and the more epidermal melanin you have, the more your melanosomes are larger. There's an increase in the number and size. And with that goes the fact that you can also have an increased risk of pigmentation, either hyperpigmentation or hypopigmentation. A lot of times you forget about hypopigmentation, and we see hypopigmentation in skin of color a lot with, cryotherapy, liquid nitrogen therapy, a little bit with electrocautery when it's too deep, but it's frequently a complication of laser. And we see it a lot in especially hair removal laser, where the setting is too strong and you wind up with hypopigmentation. The other unique properties in skin of color is the healing properties. These fibroblasts in skin of color have exaggerated responses. So our normal repair process is kind of on steroids, and can lead to these scars, and also scarring and keloid formation. So treatment options really need to be at the top of mind, to to respect these qualities. So in 2008, I developed this scale. It's the Roberts Skin Type Classification Scale. And really, the capsule summary of it all is that let the patient's skin do the talking. We don't really care what the race is of the patient, or the gender, or the age, or the ethnicity, because as I said, these emerging skin types with mixed ethnicities can really lead to unpredictable outcomes. So this scale really determines skin response. So I say let the skin do the talking. We're looking at skin response. And here is a summary of it. When you look at the table, you see 4 elements of the scale. And the 4 elements are Fitzpatrick, hyperpigmentation, glow-gout, and scarring. So we'll start off looking at the Fitzpatrick. We know that the Fitzpatrick scale measures the skin phototype. When the skin is burned and exposed to UVB, what happens? White skin always burns, never tans. Then the 2 is white skin always burns, minimally tans. I don't need to walk any of you on this call through this, because everyone knows what the Fitzpatrick is. And we all, look at our patients and determine kind of what they are. Perhaps we really should be asking the questions about tanning, but oftentimes those questions aren't answered. So the second element is the hyperpigmentation, and this is measuring the propensity for pigmentation. So how do you know if a person has a propensity for pigmentation? Look at their skin is the answer. We have to look at their skin. So you can ask your patients, but you can also examine them and ask them, do they have any spots that are brown and pigmented and due to trauma that haven't gone away? That's the best way of getting the score. And this score starts with the H0, which is hypopigmentation, which I spoke about earlier. And then next is minimal and transient. By transient, we classify transient as hyperpigmentation under a year. And permanent is greater than a year. And this is pretty much globally accepted policies when we're talking about pigmentation. Then we have moderate and transient, moderate and permanent. And then our really tough patients are this last group of patients, H5 and H6. These people have severe hyperpigmentation, and the 5 is transient, and the 6 is permanent. The next element is the Glow-Gout scale. Dr. Richard Glow-Gout developed this scale to describe photoaging. And this goes from a Glow-Gout 1, which is no wrinkles, and the signs of early photoaging, lentigines, maybe some telangiectasias, and goes all the way to the Glow-Gout 4, which is that face with severe photoaging, and it's basically like a sea of wrinkles. And we all know what that skin looks like. And also in that setting is usually, lentigines and other lesions of hyperpigmentation. Now, the last element is the scarring scale, and that describes the scar morphology. So again, we start with the S0, which is an atrophic scar, right? Because we have atrophic scars that are oftentimes caused by devices and lasers. And then we have our S1 as none, our macule, our plaque, right? And our keloid, and then the keloidal nodule, right? So that's those are the elements, and how we put it all together and make it come to life is all of these elements are separated by a slash. So an individual person would have a certain skin type. And this is the beauty of this is that this skin type can always stay with the person, and it can be communicated by text, phone. It can be written in the medical record. And when your patient transfers around or travels, whatever, they can have this skin type, and it really communicates to any physician who's doing a procedure on this person how their skin is going to perform. So let's just say in the previous slide I showed the Native American woman holding the fair blonde child. So let's say her skin type might be a Fitzpatrick 4, okay? Light brown skin, she burns minimally and tans well. A hyperpigmentation 2, when she has injury or insult to her skin, she gets minimal pigmentation but permanent, okay, for greater than a year. So right there, you know that you've got to be careful because this person can hyperpigment and it stays around for a long time. She's a Glow Gal 1. She's got no wrinkles, maybe some signs of early photo aging, and she's a scarer, right? So she can develop hypertrophic scars, basically scars within the boundary, right? Not keloidal, but a plaque that's raised, scar-like in nature within the boundary. So she develops hypertrophic scarring. And that lets us know that this person can have considerable risk, and we have to, proceed with caution. And again, the pigmentation and the scarring risks are all done from physical examination. So this is an article in the JDD, and it's also discussed more in the supplement that everyone has. Okay. Okay. So now we'll move off of that, and we're going to get more into the actual laser itself. And I just thought we needed a slide to kind of define the millisecond versus the microsecond. So, the microsecond is 1/1,000,000th of a second, okay? And so we're talking about, very, very fast times here. And the common modalities and limitations for treating skin of color, talking about the past, what could we do? Here's a listing of them, and I think we're all familiar with the limitations, but, topicals, hydroquinone, has its own, problems, rebound effect. Retinoids, people don't necessarily tolerate them. Tranexamic acid, we're just finding out about that. And, the data looks good, but we don't have enough really data here in the States on that yet. With peels, peels are effective for the epidermal pathology, but in skin of color, it's really can be risky to go down to the dermis. Although, there are practitioners that do peeling very well in skin of color and go deeper. I would say, somebody just coming out of residency or just getting started or doesn't have a lot of experience may not feel comfortable doing deep peels in skin of color. The light the light-based devices, the gold standard heretofore has been the long pulse neodymium YAG 1064. And that's a laser which is in the millisecond pulse width domain. And that presented a problem because it was not quick enough to not cause thermal injury. So even though the long pulse YAG did the job, there were always risks of thermal injury, pigmentation, and scarring, and conservative settings were, always required. Sometimes we had to do test sites, especially, on our darker skin types, and having to do conservative settings really sometimes lessened the efficacy because you couldn't go as aggressively as you might like for fear of side effects. And the other thing I want to talk about is really important is that a lot of patients seeking help for lesions were turned away because practitioners may not be familiar and comfortable with the laser. So as they should, not doing any harm, they tell patients, well, I can't do laser on you. Laser is not for darker skin. And so there's groups of patients that really could be treated but are turned away because of the unfamiliarity with the new technology. So I'm very excited about this because we can treat more people. In radio frequency, does a lot of the dermal things, but in terms of, pigment or PIH, those types of things, it doesn't really address. And it can be painful, and it can cause PIH if it's too strong. Microneedling, the limitation with microneedling, I love microneedling, and I do a ton of microneedling. But, on certain skin types, there's always the risk of PIH. And then there's always about efficacy. We're just really just starting in learning about our outcomes with microneedling. So we'll see with time how well microneedling works for these different disorders in skin of color. So now we're going to talk about the picosecond laser. So the picosecond is also a new laser, and it has a very high safety profile for skin of color compared to the traditional ND YAG 1064 long laser that we've talking about. And it's also below the thermal relaxation time, which I'm going to discuss in a moment. The problem with the pico, though, is it superheats the epidermal pigment, but it doesn't have enough power or a sufficient pulse width to break down the deeper dermal pigment. And that's why it's great for tattoos and some superficial lesions. But if you're dealing with things like melasma or post-inflammatory hyperpigmentation, you need something that's going to be able to break up that deeper dermal pigment. The pico energy is less than 1 joule at a 850 picosecond versus a much more powerful pulse of 41 joules for the 650 microsecond. So a lot of difference in power with that. As well as reaching the pigment, I like to use my Neo for rosacea. And the pico, again, lacks that sufficient pulse width to be able to coagulate those deeper dermal vascular components and diffuse redness. Practicing in Palm Springs, I see a lot of patients with just kind of this diffuse redness that I really like to go after. It might not be quite rosacea yet, but they're the flushers and blushers. And I love the Neo for this because it's able to get those deeper vessels. And there's a ton of vascular conditions that require these higher fluences and longer pulse durations than the pico. And then we see the quote here, and I know that everyone knows and is up to date that more and more we're seeing that increased vascularity is one of the major findings in melasma, as well as just the general breakdown of collagen and photo damage that we see in the dermis. So melasma treatment is evolving, and we need a modality that's going to treat all of these aspects of melasma. So our current challenges for our patients, I think this quote, this is from the supplement, which should be in everybody's mailbox. Well, it is in everybody's handout, and this is really sums it up. In skin of color patients, medical and aesthetic conditions have been treated with limited success. You know, we're good, we're better than we were, but we're not at the best yet. And we all know that light-based therapies have significant risks. So we as physicians, you know, in out there in the world, we're looking for that device, which is a go-to device that we can, you know, be the workhorse that can be safe and effective. And for me, I really need repeatability. I want a device that has repeatable results and I don't have any surprises. And I think that all of us want that. We want to feel confident. And I put here, you know, for me, I want to feel as confident with the laser that I'm using in Skin of Color as I do with a can of liquid nitrogen on white skin, right? You pick it up, you do it, you don't have to look back, you don't have to worry about it. It's predictable. You can get the job done very quickly, and we do it all day long from room to room to room. Well, I want a laser that I can do that with. I definitely don't want to create a complication. And I like to treat all the conditions with one laser versus many. You know, at one point in my office, you know, it looks like a parking garage because you have so many lasers, you know, parked up next to each other and, you know, using this one for this and this one for that. And again, that is not the most efficient way. I definitely want something with proven results. And maybe I'm fresh out of residency. I'm wanting to build a diverse skin of color practice in my community, and I really want something that I can, you know, have a go-to laser that I can use in diverse skin disorders. This is Dr. Fran Cook Bolden, who did a beautiful article describing all of this in the Journal of Drugs and Dermatology. It was done in 2011, and she says that we don't have to numb, you don't have to cool the skin. And the other feature is that it's very sanitary because the handpiece is not touching the skin, it hovers above it. You don't have to clean, you know, after each patient. So you get effective results, and you don't have to, you know, change handpiece, etc. The 650 microsecond pulse duration, the decreased thermal damage to the surrounding tissues, the lack of scarring, and the lack of pigmentary changes are all due because this 650 microsecond pulse duration is shorter than the thermal relaxation time of the therapeutic target. So we're able to get this power in a short, powerful pulse, which doesn't lead to the thermal damage. And when we can alleviate thermal damage, then there's no need for, you know, pain relievers, as topicals, and it really eliminates PIH. So, you know, the options of the things that we've used it on are acne, melasma, PIH, psoriasis, rejuvenation. Some other things are elbows and knees, you know, the pigmentation that you see on the elbows and knees. Again, in the Sun Belt, when people have their arms exposed, this is really requested. People don't like to see their hyperpigmented elbows and knees. So the Neo is great for this and, you know, clears this up. We have some cases, we didn't show it here, but we have some cases of onychomycosis that have been cleared with this technology, and we can give you references. There are, published articles which talk about, onychomycosis. So, I summary, I would say there is definitely a paradigm shift. And now, finally, we have a true go-to laser for treating skin of color. We can be confident, we have repeatable results, we have efficacy, we have safety, we have a new gold standard for skin of color.